This is a talk titled Safety Profile of Robotic Radical Prostatectomy, a Standardized Report. I want to thank Quoctrin for putting this together and for some of the graphics that you will see. A while ago, in 2009, there was a systematic review published by Ficara and colleagues in European Urology that compared complication rates for robotic laparoscopic and open radical prostatectomy. I didn't quite like the way the paper was written, because what it did is it looked at series of operations or papers in which the surgeons were doing both open and robotic cases. Historically, you would do that comparison when you were starting to do robotics. If you liked robotics and you were comfortable with it, you would gradually end up doing more and more robotics, and you would not do open cases, so you really wouldn't have an intra-institutional or an intra-surgeon comparison. If, on the other hand, you did not like robotic surgery and you thought open surgery was better, you would stop doing robotics and you would no longer be able to do the comparison. I'm not aware of any surgeon who's done robotics for 6 months who's then gone back and said, I have better results with open surgery or with laparoscopic surgery. I don't recall a single surgeon who's done that. And I'm sure that will happen at some point, but it's rare as hen's teeth. So I felt that this review had an intrinsic flaw in that it compared mature open surgery to early robotic surgery, and it was exemplified by virtue of the fact that when they looked at Henry Ford's data, they had a comparison of our first 30 robotic cases with our 5,000 open case. The paper by Srivastava and all, and it had a comparison that was the paper that was published in the British Journal of Urology that Prokar just referred to, which was our first 200 robotic cases to our 10 years of open surgery at Henry Ford. And as Ashutosh showed in the previous talk, the operation evolves. Cornell's data, his data after 2,000 cases, is very different from his data at 0 cases, and his data at 0 cases is after he had done 1,000 cases with me there. So there are two explanations for this, and I think there's part truth in it. One is that Ashutosh is getting better with age. The second is that he really had horrible training when he was with me. The data from this systematic review did not allow the superiority of any surgical approach. I think it's because of the way the study was weighted. And it ended up that there was a need for higher level evidence. What is higher level evidence, and how do you define that? We thought about looking at our own data, and we started in 2000 to set an institutional review board approved prospected database. Over years, the database has evolved. It is encrypted, and all the data are collected by a third party. And this is different from many of the databases that have reported. So our patients are polled electronically. This included our learning curve. There are 6 surgeons who do robotic prostatectomy now. It includes everybody's data. It's very hard to get follow-up on such a diverse population. Early on, 95% of my patients took a plane to come to Detroit. And what we find is after 5 years, if you keep following them, they want to get their cancer behind them. They are not interested in responding to questionnaires. But still, we had about 86% to 88% follow-up at some point or the other in these 6,000 patients. If you look at this as a series that looks at prognosis, this series constitutes level 1B evidence. It's an individual inception cohort with over 80% follow-up. This conclusion about the level of evidence was from the Center for Evidence-Based Medicine in Oxford, and the website is given there if you want to look at it. So This is an analysis now of the safety profile of 3,317 patients treated at Henry Ford Hospital. This is patient 2,000 to patient 5317. Mireya Diaz verifies the accuracy of this. All complications were, can I have the laser again, were measured in a standardized way, and the Clavian-Dindo classification, or the Dindo-Clavian classification, was used. I have some problems with the Dindo-Clavian classification. This was described for liver surgery, and it was verified for vascular surgery and predominantly open general surgery, some laparoscopic cases. It's not purpose designed for radical prostatectomy or for robotic prostatectomy. We came up with our own classification, and we compared it to the Dindo-Clavian classification, and we found a 98% concordance. So rather than opening up another can of worms and coming up with our own classification system, we used the Clavian-Dindo classification. We followed the Martin criteria, Martin-Donat criteria for reporting of complications. So this is just the way the paper is looked at. It doesn't tell you how the data was collected. It just tells you how the data was reported. And in order to have a good analysis, you should have an accurate definition of how the data was collected and how long you have followed them. You should define what you think is a complication. You should look at complications that are specific to the procedure. It's very hard to imagine that a radical prostatectomy will result in cataract. And so if a cataract is reported as a complication, it's not a procedure-specific complication. It's just a coexisting disease. There should be length of stay. It's very important to look at length of stay to look at a procedure. Outpatient information should be there. It should not just be patients who were admitted or readmitted. If they came back with a urinary leak, that should be picked up. Morbidity and mortality should be reported, and there should be a grading system, not necessarily the Dindo-Clavian. It could be the European Urology grading system or whatever. And there should be a risk stratification analysis. It stands to reason that someone with multiple comorbidities such as heart disease, diabetes, would tolerate an operation worse than someone who's young. Comparing focal Gleason 6 in a 50-year-old man, that series would be very different than if you were operating on 90-year-old people with a PSA of 50. So you have to look at risk stratification. Between 2005 and 2009, 3,317 patients underwent surgery. The median follow-up was 24 months, and the overall follow-up went up to 5 years. Mireya finished the analysis in 2010. She wanted a minimum follow-up of 12 months. The technique that we used was the VIP technique. 5 surgeons were involved. Dr. Peabody and I, we consider ourselves experienced because we'd done more than 500 cases at the beginning of this. 3 other surgeons were just starting and learning the procedure during this analysis. This was not a 30-day complication rate. If you had your procedure in 2005, and you presented with a bladder neck contracture in 2009, we captured that and we listed that as a complication. I mentioned this because many complication rates are surgeon measured on a clinical visit and had a follow-up of 30 days to 6 weeks. That's it. So if you got through the 30-day period, it was considered that you had no complications. We used multiple different database sets to measure the complications. The electronic medical records, Henry Ford has had computerized medical records since 2000. And that we included the medical records, the operative notes, and the nursing notes. We looked at all of that to capture it. We use claims data. The most accurate way of looking at complications in the United States is claims. Hospitals employ hundreds of people to look at the bills and to bill people, and so the claims data would capture any complication. It's their salaries depend on their capturing whatever goes wrong with the patient, because the hospital's reimbursement depends on what's going on. We looked at every single discharge summary that was handwritten, and we looked at our own prospective database, the database that I just talked to you about that Mireya Diaz maintained. We went to the outpatient and emergency room, and we got all the emergency room records of anybody with this code to see whether anybody appeared in the emergency room. It didn't matter when. 5 years later, if they had an outpatient or an emergency room visit, we captured that. And our institution maintained morbidity and mortality. There's standardized M&M recordings that we have to do to maintain Medicare certification. We looked at those from an institutional issue. Since many of the patients came from outside, we corresponded with the patients and the physicians in the hospitals directly. And finally, the hospital mandates the National Surgical Quality Improvement Program, where charts are picked up at random. Each chart is analyzed for 8 hours by a nurse abstractor who has had several dozens of hours of training in how to capture complications. And these people are not urology specific, they are also vascular surgery, pancreatic surgery, and all of that. Their whole purpose is to make sure that the data are captured accurately. And all of this went into a comprehensive complication data set that was maintained by Jesse Salmon and Kwok Trin. So there were 3,317 patients, of whom 90.2% or 2,991 had no complication whatsoever. 8.6% of patients had one complication, 40 patients had two complications, and three complications occurred in one patient. So overall, there were 326 patients, if you just add this all up, who had complications, and they had 368 complications. Most of the complications were surgical. There were only 79 medical complications, of which 6 were considered major medical complications. I think this expresses the power of robotic surgery in a nutshell, the power of minimally invasive surgery. What is minimally invasive? By definition, it invades the body less. And if it invades the body less, that allows the body to heal better, and it avoids medical complications. A minimally invasive operation might conceivably result in more surgical complications because your exposure is limited, your retraction is limited, and your skills might not be that great. But if it is truly minimally invasive, it should result in less medical complications, and that clearly is what we saw. 6 major medical complications in 3,317 patients is astonishingly low. This is a Nelson-Allen curve of complications. When you look at these curves, you have to have on the x-axis the number of patients at risk, and you can see that there were 3,317 patients to start off with, and 1,071 patients with a follow-up of over 1,000 days. So it's very, very robust reporting. The incidence of surgical complications continues to go up. It hasn't plateaued as of yet. This goes from 0 to 10%. So the y-axis is not 0 to 100%. At 30 days, the complication rate is around 2%. So had we reported a 30-day complication rate, our rates would be lower. So the overall medical complication rate was 2.2%, major medical complications was 0.2%, overall surgical complication rate was 5.1%, and the major surgical complication rate was 3.6%. The most common major surgical complication was a urinoma requiring a percutaneous drain. I personally don't think that that's a major complication, but the dentoclavian classification, because it is an interventional procedure, calls it a major complication. So we concluded that robotic radical prostatectomy was a safe operation with an overall complication rate of 9.8%. Most of the complications occurred within 30 days of surgery. The later complications that you see here are bladder neck contractures and lymphoceles. We have about a 2% lymphocele incidence up to 5 years of follow-up. Somebody asked that question earlier. Lymphadenectomy is done in the vast majority of patients, but we have seen lymphoceles in patients who have not undergone lymphadenectomy. When you remove the prostate, you are interrupting lymphatics, and if the patient wants to form a lymphocele, he will form a lymphocele. Well, up to now, what I gave you was level 1 evidence. Now I am comparing it to various open surgical series, and this brings it down to a review of case series. So this would be level 4 evidence. It's slightly higher than expert opinion. We modeled our paper on a seminal paper by Rabbani and colleagues. This is James Eastham and Peter Scardino from Memorial Sloan Kettering. They looked at their complication rates for about 3,500 open radical prostatectomies and 1,130 laparoscopic prostatectomies done by experienced laparoscopic surgeons. They looked at OR times. The blood loss for open surgery in their hands was 1,100 cc's. For laparoscopy was 250 cc's. The length of stay was 3 days and 2 days. The overall complication rate was 27% and 39% for open and laparoscopic surgery. The medical complication rate was 11% and 19% for these cases, and the surgical complication rate was around 28 and 30%. You saw our complication rate was 9%. Our length of stay was 1 day. Our blood loss was 100 cc's, and our operative time was 160 minutes. Early on, during our comparison, from 2001 to 2005, and this predates what we just looked at, we simply looked at hospitalizations and length of stay. Remember, length of stay is an important verifier. And at that point, we were still doing open radical prostatectomy. There were 2 surgeons, one being me, who did most of the radical prostatectomies. When we started our program, we had a care path for open radical prostatectomy, a care pathway. Everything was done in a standardized way. People were fed when they met certain criteria. Pain medication was given when they had certain criteria. And the care pathway was based on Vanderbilt's care pathway, and it was created for open radical prostatectomy. And in the care pathway, our goal to send patients home was at 3 days. And what we found was that perhaps 40% of our patients, between 40 and 50% of our patients, actually did go home at 3 days, which is exactly what we saw in Rabbani's paper. The median length of stay was 3 days for open radical prostatectomy. Also importantly, 11% or 10.5% of the patients stayed in the hospital for 1 week. And at Henry Ford in the United States, nobody stayed in the hospital for 1 week after a radical prostatectomy unless they were having a major complication. It simply wasn't allowed. You'd have a nurse abstractors come. You would have to answer to administration why you were keeping a patient in for a week. You'd have to justify that with a complication. You couldn't keep them for social reasons. For robotic radical prostatectomy, case 1 to case 1999, we saw that 90% of the patients left in 1 day, 93% of the patients left in 2 days, and 96% left in 3 days. 0.8% of the patients stayed in the hospital for more than 1 week. So this is clearly objective data. If you just looked at hospitalization for greater than 6 days, during the learning curve, we went down from 10.5% for open radical prostatectomy, contemporary comparison to 0.8%. This is about a 90% decrease in bad outcomes, which is tremendous. However, this is a single surgeon series. I would like to say it represents best practices, much as Dr. Abbas's, Dr. Badani's, Dr. Himmel's, Dr. Ra's, and Dr. Tiwari's series would. It is not community standard. It is not something that you could achieve if you were doing 4 robotic radical prostatectomies every year. At least I would imagine not. Kwok Trin, who collected this data, together with Pierre Caraco, which then looked at the nationwide inpatient sample. And this is a voluntary group of hospitals that would record perioperative outcomes for every operation they had in every field. And 20% of all hospitalizations of all hospitals in the United States, acute care hospitals, voluntarily report this, and it's part of the nationwide sample. You can get the data. You cannot do individual comparisons. You can only do global comparisons. This does look at patients no matter what age group it is. It's not a Medicare-based database. Medicare is only for patients over 65. This constitutes level 2C evidence or outcomes analysis by the center as defined by the Oxford criteria. And it's online in European Urology. And what they did is they looked at about 12,000 robotic prostatectomies compared to about 6,000 open radical prostatectomies. Maybe it's 20,000 and 10,000. And then they did propensity score matching, trying to match the two groups. The blood transfusion rate for robotic prostatectomy was 2.2, with 7.7% for homologous blood, allogeneic transfusion, not autologous transfusion for open surgery. The intraoperative complication rate was 0.4% versus 1%, and each one of these differences was statistically significant because of the large mass of data. The postoperative complication rate was lower. The prolonged length of stay was 14% in this group. Patients stayed more than 2 days compared to 39% of the open cases. There was no death among these 10. There was actually 1 death for 10,000 robotic cases compared to 1 death per 1,000 open cases. And all of these were statistically significant differences, or most of them were, as you can see by the p-values here. A p-value of less than 0.001 suggests that if you repeated this study in 1,000 populations, in 1,000 times over, maybe 1 out of 1,000 would it be by random occurrence that you would get a difference in complications. So contemporary data from the United States demonstrate that robotic radical prostatectomy has supplanted open radical prostatectomy as the most common surgical approach. I didn't allude to that in this, but essentially it showed that in 2009, 66% of patients undergoing surgery for prostate cancer had minimally invasive or robotic radical prostatectomy, and 30% had open. So open is not completely disappeared. It's about 30%. Most of the patients who had open radical prostatectomy were done at rural hospitals that had no access to the robot and that were at low volume hospitals, which probably explains the difference in outcomes. Most of the robotic prostatectomy were done in hospitals that did a fair number of cases. So the average number of open radical prostatectomies per hospital was around 10 to 15, and the average number of robotic cases per hospitals in this analysis were around 70 to 80. The uppermost quartile for robotic case was 280 cases, and we, as well as Dr. Abbas and Dr. Badani, are well over 280. The adjusted analysis, adjusting for hospital volume, as well as all the other comorbidities, showed superior perioperative outcomes for robotic surgery in virtually all of the examined outcomes. Parallel to this is another paper coming from Jim Hugh. Jim Hugh wrote the first paper in JAMA that looked at Medicare analysis, and this is an updated analysis. He looked at the first year in which coding was available for robotic cases, and so did the national inpatient data. Up until 2008, there was no code for a robotic case. You really didn't know whether somebody had a robotic operation based on claims data. You could call them and ask them, but you couldn't measure it in a population-based study. Jim looked at 100% of the Medicare sample, so there were no exclusions. These are Medicare patients, which meant in order to have to be enrolled in Medicare, by and large, you have to be 65 and older. You wonder why a 65-year-old man is undergoing a radical prostatectomy, but that's a different question. A fairly sizable series. There were 11,000 robotic cases and 45,000 open cases done in Medicare. He looked at the stuff that he had found was bad about minimally invasive surgery in his early study, and he found that the anastomotic rate was significantly lower, ureteric complications were significantly lower, fistulas were lower, fistulas were the same, lymphoceles were lower, and surgical intervention with incontinence was about the same. Anastomotic strictures and lymphoceles were considerably lower with robotic radical prostatectomy, as were all the other parameters that he looked at: length of stay, any perioperative complication, cardiac, GU, miscellaneous medical, miscellaneous surgical, respiratory, vascular, wound, depth. So if you combine these two series, you now have close to 100,000 patients in 2009 in whom the comparison was done in the United States. One is a random population, which is not age discriminant, and the second is the Medicare complication. And the conclusions are virtually identical. So Jim Hugh found that robotic surgery was associated open surgery was associated with increased mortality rate, about threefold higher. 2.67 was the odds ratio, with a confidence interval of 1.55 to 4.59. And because it's such a large series, the likelihood that this is a chance occurrence is 1 in 1,000 or less. And open surgery was associated with more perioperative complications and more later complications, again, at a statistically significant level. So I think the conclusion for me is that as the procedure has evolved, we are seeing that this procedure is robust and it is safe. Thank you.
Thank you, Dr. Menon. And before I open this talk for any question, I'll ask one question from you. Because you were the pioneer and you never had a mentor in your program. Now we have this robot, so we get mentor, we are trained rather. So in the beginning especially, how many of the patient you had converted to open surgery? Maybe because of complication or during surgery?
I don't think we converted many. The way we started the program was that and we told the patient this: if the operation took more than 4 hours, we would open you. We did not want to have the patient in steep Trendelenburg for over 4 hours. And we started off doing laparoscopic surgery. Batan Guillermo and Guy Valencian came and did the cases, and we would convert at 4 hours. I think we converted 3 of the first 30 who had straight laparoscopy. When we started robotics, we had that history about this. I recall one conversion in the robotic population. This was somebody who had a bleeding diathesis, a liver dysfunction, and I was just unhappy with the visualization. I remember after doing the case, Ashutosh telling me, Dr. Menon, you shouldn't have converted him. You've spoiled our results. But I couldn't see. And I was uncomfortable about that, and so we've had one conversion from failure to progress. We've not had a single conversion from an iliac injury or a ureteric injury in the prostatectomy patients.